Today, I want to examine the role of naming in psychiatry through a historical and conceptual lens. In ancient Egypt, a person's name was believed to hold intrinsic power. To know someone's true name was to gain influence over them. For this reason, individuals often carried not only a public name, but also a hidden private name, known only to close family members. This practice served as a form of protection against those who might attempt to cast spells or direct harm toward them. The Egyptians understood something fundamental. A name is not merely a label, it is a mechanism for defining existence. If something has no name, it effectively does not exist within the conceptual world. This idea has surprising relevance to modern psychiatry. Psychiatry deals with phenomena that are often immaterial, experiences that cannot be directly measured through chemical assays or visualized through imaging studies. Thoughts, emotions, behaviors, and subjective states do not lend themselves easily to objective quantification. Because of this, the field requires a systematic method for defining and classifying mental disturbances. There are two primary reasons for this need. First, we require a concise way to summarize complex patterns of disturbance so that clinicians, patients, insurers, and other authorized parties can communicate clearly and efficiently. A diagnostic term condenses a large amount of clinical information into a form that can be shared and understood. Second, we need distinct diagnostic entities in order to study them, compare them, and develop targeted treatments. Without categories, research becomes incoherent, and therapeutic interventions cannot be systematically evaluated. Transforming abstract psychological phenomena into concrete diagnostic language is a complex and continuously evolving process. This effort formally began in 1952 with the publication of the first edition of the Diagnostic and Statistical Manual of Mental Disorders. That initial DSM was rudimentary, consisting largely of paragraph-style descriptions. From those beginnings, the nomenclature has evolved into DSM-5, the most advanced and structured classification system currently available. It is important to note the terminology. We speak of disorders, not illnesses. This distinction reflects the fact that in psychiatry, there is rarely a single, well-defined cause. Unlike pneumonia, which can be traced to pneumococcus, mental disorders typically arise from multiple interacting factors. Furthermore, these conditions exist on spectrums, with gradual transitions from normality to mild, moderate, and severe disturbance. The boundaries are not as sharply defined as those of a bone fracture, where the difference between intact and broken is unmistakable. The latest DSM is grounded in extensive statistical analysis of how symptoms cluster together. In principle, the diagnostic process is straightforward. Each disorder includes a list of possible symptoms. A minimum number must be present. They must persist for a defined duration, and they must produce clinically significant impairment, either by limiting the individual's ability to function in daily life or by causing emotional distress to the patient or to those around them. At present, the DSM describes 298 distinct disorders organized into 22 categories. While the definitions themselves are clear, the true skill of clinical practice lies in determining when a criterion is genuinely met. Some symptoms are difficult to elicit. Patients may minimize symptoms to avoid a diagnosis or exaggerate them in pursuit of one. Others may lack insight into their own experiences. For this reason, clinicians often seek collateral information, observations from family members or close contacts who have witnessed the patient's behavior firsthand. Collateral information is a substantial topic in its own right, and one that merits separate discussion. For now, the central point is this: Just as the ancient Egyptians recognized the power of naming, psychiatry relies on naming to bring structure to the intangible. By defining disorders, we create a shared language that allows us to understand, communicate, and ultimately treat the many ways in which the mind can break down.